dictates and indicates our bias. So it's my challenge and my privilege this evening to offer a set of stories, each with their own beginnings and biases, that answers this brilliantly simple question that Emily and Jay approached me with, which is, why is there a health gap? You might want to write that down and start playing with it, because I don't know that I'm going to give you the answers or the beginnings that you need. I'm going to be focusing in this discussion on global health, which is what people in America call health outside of America. I'm an American who works in global health, and I know more about the dynamics of health inequity beyond my borders than I do here in my own country, though I stand in solidarity. But in that way, my life's work is both a search for a solution and part of the problem. So I dwell in that complexity as well. So why does my computer go to sleep while I'm talking to you? Why is there a health gap? Another way, perhaps, to phrase the question is, why is there an AIDS epidemic? And you can think about whether those are the same or they're different. Here's one story that answers both questions. There is a health gap and an AIDS epidemic because of extractive colonial practices, specifically those practiced in Cameroon and Congo and other countries in West and Central Africa, where simians or non-human primates carry a virus that is related to HIV but does not make them sick in their blood. In order to get the resources they desired from that unceded land, Belgian colonizers conscripted African men into a slave labor force that they both brutalized and, because it was their labor force, took an active interest in keeping sufficiently healthy to be able to work. These men came from villages where perhaps one or two or few had come in contact with the simian virus, but those cases had been few and far between, and the people had died undiagnosed. The aggregation of large numbers of conscripted Africans into urbanized centers where they were explicitly forbidden to have families, where women and children were not welcome, but where sex workers were both allowed and imported, changed the sexual networks and the conditions for viral spread. Jacques Pepin, who wrote this book called The Origin of AIDS, having reviewed the health records kept by scrupulous colonial record keepers, believes that the constellation of conditions recorded by them maps to the conditions that define what we call, and they did not call, AIDS. Why is there a health gap? Why is there an AIDS epidemic? Here's another option. They're not exclusive, these stories, these beginnings. In 1978, in the city now known as Almaty in Kazakhstan, and then known as Alma-Ata, at the International Conference on Primary Healthcare, which was organized by the World Health Organization and UNICEF, 134 countries signed a declaration committing to health for all, with an explicit and specific focus on access to primary health care. And this is an important term to note, and it points us to kind of a corollary of my friend Ted's idea, which is where you start your definition of health defines your actions and shows your bias. So I'm going to come back to that, but let me say this for now. That statement, the nation states that adopted the Alma-Ata Declaration and said that they shared a commitment to primary health, meant that they were going to pay for the services that allow people to stay healthy. Immunizations, antibiotics, anti-malarials for areas where malaria is endemic, clinics with people to treat you, warehouses to hold medicine, trucks to drive the medicine, people to order the medicine, and more. It's in 1978. And yet, in 2004, the year that free AIDS drugs arrive in Uganda, the head of the American CDC program there, John O'Merman, testifies before Congress, a Senate committee interested in this new AIDS drug program, and he says about Uganda, the health infrastructure is worse now than 30 years ago. Most hospitals do not have working X-ray machines, basic laboratory testing, or a reliable supply of simple medicine. On any given day in Uganda, only 5% of health facilities can perform an HIV test, and only 20% can diagnose and treat tuberculosis, the leading cause of death for persons with HIV in Africa. By the time Merman testifies, 6 to 7% of the Ugandan population has HIV. The nation is closing, though, in on its second decade of relatively consistent economic growth and stability under the leadership of Yoweri Museveni. Why is the health infrastructure worse than it was 30 years ago? Where you start the story dictates your actions and shows your bias. I will say this, and we can talk about other reasons. Museveni takes power. He has a dalliance with North Korea. He thinks about socialism and bartering. And then he realizes that he's not going to stabilize the country's economy by taking that route. And he embraces the World Bank and the International Monetary Fund's prescriptions and conditions for loans. He embraces them so much that Uganda becomes the poster child for the World Bank. Museveni writes something called a Poverty Eradication Plan, Action Plan, or PEEP, and it becomes the template for the poverty reduction strategy paper that becomes the World Bank prerequisite for any country seeking debt relief. Wait, what? Debt. Yes, debt. Museveni has gotten loans from the International Monetary Fund. As a condition of those loans, he has done what the IMF asked, a series of interventions known as structural adjustments that stipulate that countries have to control their domestic costs. They have to freeze hiring. They have to cap salaries. They have to do so in the health facilities, in schools, and in other places where a public sector is needed to care for the people. By the time Museveni has developed the plan that the World Bank loves so much, he and his country need debt relief. And the primary healthcare system that was a goal from the 1970s has been rendered impossible, not through lack of resources, but through structural adjustment policies. And I would also say lack of interest on the part of people with power, both in Uganda in this case, and in other countries that were receiving loans, and also on the part of the people that were giving the loans. There is also the increasing pressure of repaying debt, which is right now at this moment being clocked as a driver of COVID. So this is current. We're in our time machine. We're going to go all over. Right now, ActionAid just did research, that they're contextualizing with COVID and the inability to muster a response. 30 low-income countries with the highest debt repayments, totaling more than 13% of government revenue, their public spending has fallen by 6% in recent years, okay? In low-income countries, the same number, 30 low-income countries where debt payments are below 13% of their government revenue. That's a lot of your economy. Public spending grew by 14%. So when you're not servicing your debt, you're able to spend on the public services that you need, okay? Why is there a health gap? Why is there an AIDS epidemic? Perhaps that is also both an answer or beginning to the story. Here's another one. Why is there a health gap? Because George W. Bush's father loved condoms so much that he got the nickname rubbers. True fact, fun fact. He really did. He and other white men, like John D. Rockefeller, loved population control, okay? They loved it, but they did not love women's bodies. Bush Sr. implored the UN to start a fund for family planning. The US government provided the seed funding for said family planning. However, those tote bags that we get from Planned Parenthood, or people see them, I went to Planned Parenthood, it's got all this fine print, and I got a pap smear, and I got a breast exam, and I got my blood pressure checked. That is these guys' worst nightmare, right? Is that their family planning, their population control money is going to go and pay for anything else. So USAID, our Agency for International Development, as a condition of paying for contraception, imposes a firewall between contraception and all the other services women need. So remember when I said, why is there a health gap? And how we define health dictates our actions. When you define health as hospitals, so where countries who were trying to build their health systems did have money in this whole period between Alma-Ata and the beginning of, let's say, free AIDS drugs, the money's going into PEPFAR. Why is there a health gap? How are you defining health? When you tell a woman that the only thing you care about is preventing her from getting pregnant because you want to control the population, because that's key to economic growth, which is why they wanted to do that, you are defining health in a way that creates a health gap. The way that you define health dictates your action. Why is there a health gap? So one of the things that I love about this question is that it's a pun, right? And I'm pretty sure that they meant it that way. So I'm going to take the bait. Okay. There's a health gap, and Emily talked about this, but I'm going to do a little bit of a recap. There's a health gap because after the advent of antiretrovirals in America in 1996, a group of activists, including a physician and former political prisoner named Dr. Alan Berkman, took stock of inequitable access to AIDS drugs in Africa and decided, and in other parts of the world, and decided that it was immoral and unacceptable. That is a nice and true and huge thing to think. Then what do? You take, if you are a health gap, you take a problem and you cut an issue out of it. If you are the folks on this call, You know this, Richard Stern, I know you know that you take a problem and you cut an issue out of this. This is what you guys are building power, what we are building power, we're gonna keep on doing no matter how big the problem looks. You cut the issue out of it. They looked at this issue of lack of access to AIDS drugs in all of the places that people were getting HIV and dying of AIDS. They looked at this and they tried to figure out where to start the story because that would dictate their actions. So they talked about reparations and they talked about the ravages of colonialism, but they did not start the story there, or not exactly. They started the story with the engine of colonialism and the modern world, capitalism. Also, too big to tackle head on, right? It's not cutting an issue yet. They cut the issue further. The problem that they then identified was that South Africa had, in its post-apartheid legal framework, passed an act that explicitly stated that it had the right to make or import essential medications, even if those medications were patented. And there are two provisions specifically. One is called compulsory licensing and one is called parallel importing. And I can define those or break those out for you, but they are the legal framework that allows countries to obtain the medications they need, even if there is a company that holds a patent for that. So it's basically saying my right to get the drugs that I need for my country or my clinic or my family is more important than your profit, which is patents protect profit in this case, okay? If they were able to bring these drugs in generic form, or they could be made generically, South Africa wanted to be able to bring them in. Now, not specific to antiretrovirals, this was a Medicines Act, so it was broader than that. And actually South Africa and AIDS activists and the government have a very complicated and powerful activist history of securing access themselves, which we can talk about if you want to. In this case, I'm talking about the Medicines Act. South Africa had it. The US government, then led by Bill Clinton and Al Gore, did not want them to have the right to bring in those medications, or rather their donors, the pharmaceutical lobby, did not want them to have the right to make or import essential medications. Not because South Africa was a market, but because the principle of access to medications went counter to their profit-making story. When I say not because South Africa was a market, you could just say that, it may be true. Part of the, I mean, it is true and it's easy to say, but the part of the legal strategy of the Treatment Action Campaign, which fought the drug companies in South Africa as the health gap activists were fighting in America, was to bring a lawsuit, to prepare a lawsuit against the drug companies. It's called Hazel Tau, T-A-U is the last name. They never brought it because the drug companies caved, but essentially they were saying, you need to produce the evidence that shows that we are even enough of a market for you to be making hay about your patents. You need to prove. So they caved and they changed their practices. They agreed South Africa was not a market. Okay, so that for every statement, almost every statement you will encounter in the history of the struggle to close the health gap, there is a story behind it of activists challenging the world as it is and demanding that it change. Okay. So the way that Clinton and Gore show that they don't want the Medicines Act to be in place is by putting South Africa, along with Brazil and Thailand, which are both permissive and permit themselves, permissive in terms of their ability to make or manufacture or import generic medications, they put them on something called the 301 watch list, which is a list held by the US Trade Representative's Office. And if you're on that list, you're a step away from trade restrictions or sanctions. So it's, okay, we see you. So there are loan conditionalities. There are also trade conditionalities, right? If you want to play with us, if you want our money, if you want to be part of our markets, you have to play by our rules. Structural adjustment and loan conditionalities are one way, trade conditionalities are another. So basically we have now activists that go, okay, colonialism in the modern world, capitalism, too big, definitely the main issue, definitely the problem. We got to cut it down. Okay, what is going on here? What can we take on? One of the things we can take on is Al Gore and Bill Clinton standing behind Big Pharma as they bring a lawsuit against South Africa over the Medicines Act, and the US government puts South Africa, Brazil, and Thailand on a trade watch list because they are making or want to make or import generic AIDS drugs. I mean, at this point in history, to say this actually happened, there's nothing boggles the mind anymore, but this actually happens, right? This happens in 1999. So you're cutting the issue, you're cutting the issue. Okay, behind every issue, I learned this from Sharon Ann Lynch, who's one of the founders of Health Gap, a formidable, amazing activist. And she once said to me, behind every issue, there's a person. And that's what you're doing. When you're cutting an issue down, you're getting it as focused as you can. And behind that issue, there's gonna be a person. And guess who that person is in this instance? That person is Al Gore, because he's about to declare his candidacy, his presidential candidacy, okay? This is June 1999. So a group of people get together on 11th Street and they're sitting around and it's like, what are we gonna do? What are we gonna do? It's, you know, we gotta do something. I know, he's declaring his candidacy in Carthage, Tennessee. Like in 2 days, we're gonna rent a van and we're gonna drive down and we're going to disrupt his campaign, okay? So do we need tickets? Do we not need tickets? Oh, we'll probably be able to get in without tickets. So they get nice shirts that say Columbia Students for Gore. They rent a van, they drive down, they show up. Oh, you do need tickets. So then Mark Milano, one of the organizers, another stalwart, goes over to the nicest looking grandma he can find. And he's like, we came all the way from New York. Mark Milano, by the way, God love him. He's a beautiful man. He does not look like a college student, even in 1999, says, you know, we came all the way. Can you please just let us in? They get it. Okay. So there's lots of little activist tidbits, right? Along the way. Make your t-shirt, or make the t-shirt that'll get you in, and find the person and sweet talk and all those good things. And you've got to find people who are willing to ditch their jobs for 24 hours or 48 hours. All this stuff matters. This is how history gets made. They get in. Mark Milano has the whistle. They have to figure out when they're going to disrupt Al Gore's speech. And it's not when he's talking about women's rights, and it's not when he's talking about, you know, sort of liberal policies, but then he says family values, and it's like, that's the time. So Mark Milano blows his whistle and people start chanting, and all these people that they've been chatting with who, while they were waiting for him to start, are like, oh my God, what is going on here, right? The next day is the first time in the history of the New York Times that the phrase AIDS drug for Africa is in the paper, okay? The reason you drive all night and you get your t-shirts and you sweet talk the grandma and you do all that stuff is because you have somebody working press and you get to the media, okay? And it works. They get back in the van and they drive back up north and they zap Gore in New York, and then they get in the van again and they drive to Manchester, New Hampshire. And they're so cute, and it's a different group of activists that this time they put them behind Gore while he's speaking, and they have a great big banner and they hold it up while he's speaking, right? So his people put together a list of reasons. What do? They do a couple of things. And this is another piece that's just interesting to slow down because this happens all the time, right? So Donna Brazile is working for Al Gore at this point, okay? You don't know who she is, we'll talk about that later, but Donna Brazile, and she knows Paul Davis, who's one of the organizers, because they met at a political funeral for another activist. So Paul is leaving the Manchester Action, and Donna comes running up and is like, what do you want? And he's like, I want you to, and he rattles off the demands, right? Take South Africa off the watch list, stop intimidating countries, open the doors for generic medication, and stop being a pro-profit obstructionist force in the fight for AIDS drugs. So you got your t-shirts, you drive all over the place, you always know what you want. So he gives it to Donna, okay? He says, and I want you to write a letter to the Congressional Black Caucus telling them that that's what you're going to do, because we're getting the Congressional Black Caucus to write to you to find out what your commitments are. So you get your allies in government as well. You will always be able to find allies in government, and you get them on your side. Donna is an ally. There are other folks in the Gore camp that are allies, and then the Congressional Black Caucus gets on board. And when they get their answer from Gore, they don't like it, okay? So there's a whole inside game. The inside-outside game is happening this whole time, right? Paul Davis is both dropping the banners. Sharon Ann Lynch is dropping the banners. Mark Milano is dropping the banners. All these folks are doing the protest and doing the negotiation. A lot of the sort of sexy, street smart, amazing activism that we see, all of it, in fact, is the tip of the iceberg. And there's a whole bunch of stuff going on behind it. So if you are not the person that wants to be out in the streets, there is a ton of other stuff that's happening that you can make happen, right? So what happens next? Okay, the Congressional Black Caucus asks for an explanation. it's a really crap explanation. The activists just don't stop. They keep on zapping him. Okay, they show up everywhere he goes. He goes to Philadelphia and they turn out ACT UP Philadelphia. Woo woo! If anybody's on from, okay, a vibrant chapter of ACT UP that after the advent of AIDS drugs, when other chapters are kind of going through a little bit of a grappling of with the changing face of AIDS in America and the changing face of activism, right? ACT UP Philadelphia builds from the ground up, former drug users, veterans, people of color. It is a vibrant, badass group to this day. So ACT UP Philly turns out in Philly to zap Gore to be like, it's not just the pretty white kids that you put behind you at Manchester. It's all these people care about your position on this. And people just get tired. And there's all this email traffic back and forth. They're like, can we just make them go away? Like, what's going on here? And then they're gearing up to do another major Gore-focused DC protest in October. And suddenly the US Trade Representative's office has news that they've reached an agreement with South Africa and it can get the medications it needs and the US won't interfere. Okay? So the activists turn out and are like, that's really great. You have to do that for every other country. Okay, so why is there a health gap? Meaning the organization. There's a health gap because if you are able to take the problems, which are enormous and daunting and heartbreaking and crushing, and cut the issues out of them and knock down the issue, right? I think of those like, do those exist anymore? Those Weeble Wobble, those like inflatable things that you could punch. I feel like I haven't seen one since the 80s. Anyway, somebody tell me anybody grew up with those, but you like, you knock down the issue and eventually you get a glimpse of Al Gore or whoever your target is. There's always somebody behind your issue and there's always something specific enough. And if you show up again and again and again, someone will ask you what you want and you will have the answer because you are working with smart people who've done their homework and you will provide the answer and you will also have the bodies in the street and you will keep showing up. And eventually, if you have cut your issue well enough and finely enough, you will win. And sometimes it takes decades and sometimes it doesn't. And sometimes it takes lifetimes and sometimes there are struggles like some of the ones we're in now that I'm not sure I will see the end of. One of the remarkable things about the fight for AIDS drugs for Africa and the health equity that was encompassed in that slogan, right, is that a lot of wins happened in a really short amount of time. But I do want to say this. Why is there a health gap? Goes back to what I was describing at the beginning. When the drugs arrive, when they start to arrive in 2004, and John O'Merman is testifying before Congress, they are in countries which have been dealing with debt and structural adjustment for decades. They don't have the primary healthcare systems with which to deliver them. So there's a choice that's made, and it's made differently in different countries. It's made differently in different portions of countries, but essentially the US government, which becomes, as the result of a whole cascade of additional interventions and really astute activist inside-outside game playing, it's not a game, high stakes work, becomes the single largest funder of global AIDS in the world. And they want to get drugs into bodies. All of a sudden, they really, really, really want to get drugs into bodies. The countries in which they want to get those treatment have no health systems for reasons that have to do with structural adjustment policies that the government itself has aided and abetted. So now we're faced with this choice between building a health system and getting drugs into bodies. And to get them in fast, you're going to work outside of the health system. And this is a really tricky thing. It's a tricky thing to understand about AIDS drugs. It's a tricky thing to understand about American investments and other investments in fighting AIDS, is that there was a moment around 2004, 2005, where the pills arrived and the money arrived and people had a kind of a conversion moment about antiretrovirals in the context of countries that did not have primary health care because of some of the reasons I described and other ones that I didn't, okay? So why is there a health gap? It's all of those things. It's why we have the activist group doing the fighting, but it's why even after winning AIDS drugs for Africa, which many of us at the time described as the thin edge of the wedge, we're going to win AIDS drugs and then people will understand they can demand the other things that they need and we will keep going and going. And we did do some of that. And African activists did do some of that. And we have done some of that in the US. The reason why we haven't gone farther has to do with what happened before. So part of our activism is knowing what happened in the past and knowing what we're picking up from, whose work we're carrying on, and what we want to leave behind. So I gave you a bunch of beginnings. I don't have the answer. I don't have the end. We don't have it, right? But I think these are the questions. Why is there a health gap? Both the movement and the organization and the chasm, okay? Why is there an AIDS epidemic? And of course, the question that I think is for so many of us present right now, right, is why is there a COVID epidemic? So thank you for giving me a chance to start the stories, and I look forward to ending it with all of you.
Thank you, Emily.
Thanks.
Definitely. You encourage us to take notes. I took some, took my own notes. Oh.
I didn't really mean take notes. I kind of meant, sorry, that might have sounded really like bossy. What I sort of meant is like, I can't pay attention to anybody for any amount of time, but I have found that if I'm doodling, I can. That's sort of what I meant.
That's how I focus. Yeah, that's
okay.
Does anyone have questions or like comments about the beginnings that Emily has offered us? See in the comments, people are saying that it was very informative.
Any questions from anyone?
I mean, I think one of the, well, let's just turn it around, right? Like, why is there a health gap, Jay?
Oh, me? So
I mean, let's just, what do people, because you could start this story in so many places. Like, I'd love to hear what other people's, you know, maybe it's not about whether the people have questions, do people have answers?
Yeah. Very good. Very good point.
Does anyone in the group want to?
I'm gonna jump in and just take a stab at this. Hi, my name is Marco. I go by he, him, his. And this is my first time ever attending something like this. So thank you for creating the space and also for having such an informational session. And when you ask, like, you know, why do we have the health gap? I just think that based on a lot of the information that you shared and what I know in general, there are people who want to keep other people down. And when you mentioned big pharma and the money aspect, I think that's why we have a health gap, because there are some people that want to monetize out of the despair of others. And we would hope for everybody to have a better sense of human being, right? But that's just not the reality of what we have. So we're living with this health gap issue that we are trying to bridge. However, there's always so many people and so many instances that push us away from making that bridge because someone wants to be at the top calling the shots. And a lot of the times the shots are being called because they want to make some money out of it.
Mm-hmm.
I just wrote monetize out of the despair of others. Thank you for that. That's a deep articulation of one of the things that's going on here.
I met Health Gap in 2000, the year after they were formed, and I met them in South Africa. And the thing that struck me most about what was going on then, and you know, the drugs are available to us and to me and to people in the global north. But it's really also about not letting people just get away with saying things like, well, it's just not affordable. We just can't do it. And people say, no, that's not okay. You know, just having the guts to like just say that's not okay. You know, people have a reason for saying that thing, but it's just not an okay thing to like get away with. And it's calling people out.
If we were in person, I'd be like writing all of these on a whiteboard right now.
I'm writing on my index card. It's totally true. It's the courage to just be able to say you're wrong, and you don't have to have an answer. That's the other thing. You do have to have your homework for a certain amount of this. This was like because I was like running around in my footy pajamas when all of this was happening. Like nobody really, so they won the AIDS drugs, right? They get some of the trade barriers removed. They get the prices to come down. There's a whole story about generic manufacturing and generic AIDS drugs. And then it really is, as I, like, you know, one of the activists involved in this sort of said to me, you know, and then it was like, oh shit, we need another thing, right? They got the drugs, and it's like, they need a way to pay for it. They need a funding mechanism that's going to buy it. They didn't start asking for the drugs knowing how, we didn't start asking for the drugs knowing how we were going to pay for them and procure them. And I think that that's also important to remember as you cut the issue. It is not your responsibility to have the end game. You don't have to have, the people in power have to cede to your immediate demand. It is not your responsibility to tell them everything all at once. You'll figure it out, or they'll figure it out. But that idea, you know, tell us what you need, tell us what you want us to have happen, is a great way to sort of immobilize civil society and activism. So you tell them what they want. Don't let them turn the question back, and have that demand, cut the issue, knock it down, find the person, and then find the next thing. And then when you have to figure out the next big thing, like the bulk procurement mechanism, you do.
Folks have any other like thoughts or want to offer any like voice or comment as to why there is a health gap? Particularly folks who reside outside of the United States, or even in your own areas in places where you live.
I think we have a question in the chat that says, do you think that access to medicines is sustainable if it's kept divorced from general issues about health systems? And are global health activists moving away from that distinction?
I think it's a really good question. So I think, you're gonna give me a thumbs up on this. I think A to M is access to medicines, right?
Yeah.
Okay, excellent. So I think it's a really good question. And I think that, like I said, when part of, so there really was a moment when we thought that if we won antiretrovirals, it was the thin edge of the wedge. And it was the thing that was going to drive into the crack in the superstructure and bring parts of it down. There really was a feeling about it. So access to medicines, as I encountered it and experienced it, was not at the outset solely about medicines. You know, the pills had a real symbolic component to them. They stood in for a lot of things. They were expensive. They were treating a disease that was everywhere. And so it was a way of talking about equity and talking about everybody's right to life and health and dignity, that was both the health and dignity that you had from being recognized as a person who deserved an expensive pill, but it was bigger. So access to medicine started from that, and started from this real critique of trade, capitalism, and a bunch of big picture things. When those victories happened, and when the funding went into those parallel systems that I was describing, because the push had been get the AIDS drugs and get the pills into the bodies, we then had a really difficult, challenging thing appear. When I say we, I mean the sort of AIDS activists that have been doing the demanding. I want to acknowledge that we is a complicated, I don't presume membership from anything, but the AIDS activists with whom I was sort of working and learning and writing about at that moment had to kind of decide, as I said, between speed and systems. And I think that what we're seeing now, 16 years on from winning AIDS drugs, is what it looks like when that question didn't really get well resolved, right? In subsequent years, for example, in the Obama administration, there's a global health initiative proposed, which is one mechanism for investing in broader systems, except, wait for it, they don't put new money into it, right? So they actually take money from PEPFAR to try to build health systems, and it fails because the AIDS activists go on the defensive and save PEPFAR. So that you then have when you're in a defensive mode, you're not advancing the bigger picture. And this did happen under Obama. So I think that it is not sustainable to do access to medicines on its own. I don't think that it was the intention. And I think that where we were pre-COVID was seeing a real interest in universal healthcare, right? The return of Alma Ata, and an interest in it and a concern, because you can't have universal healthcare be a least common denominator experience, which stigmatizes and shames and excludes, and therefore drives away people who, because of who they love, the substance they put in their body, the anatomy they were born with, the gender presentation, the country they come from, the citizenship they have, don't seek health services. There's a risk when you go to universal healthcare that you are going to lose the innovations that HIV has put in place for lesbians and gays and transgender people, for women, for adolescent girls. So I think it's the right question, and I don't have an answer. But boy, did I talk a lot about it. What happened while I was talking? Is there a written narrative? Yes, there is, because my computer didn't crash. I thought it did, but it didn't. Ooh, I love this. I think there's a health gap, as Charles says. I think there's a health gap because aside from all the reasons already mentioned, how the Western world prizes the biomedical and approach to health and positivist research. I strongly believe addressing the structural issues, equalizing wealth, and investing in communities to lead local solutions would be a good approach to end the gap and the health gap. 100%.
Yeah.
That's right. So this is the issue of who defines health. Who defines health is part of the issue. How do we define it? Where you start the story, where you start the definition defines your actions and shows your bias.
There was another question higher up about this person says that, or she says, because I work a lot with USAID and PEPFAR delivery programs, there's a lot of movement towards local ownership of these programs, as well as incorporating them into the local health system, but not sure if structural ecosystem will allow for this.
So this is a great question. And the country that I know the best is Uganda. So I can speak from that perspective. I moved there in 2004 when PEPFAR started and started visiting clinics with USAID and CDC funding. Those are both US entities that get money, this AIDS money, and then further spend it. And I've been going back to some of those clinics for a really long time, 2004 to 15 years, 16 years. So what is happening right now in Uganda with the bringing in and turning over resources to what America calls, and I think in a really complex construction, quote unquote, indigenous partners. They are the people in the countries that we're spending the money. I'm not really sure why we call them indigenous partners, but when you work in this field, you start to say those things. So PEPFAR has decided that the government national medical stores has to do all the drug procurement. Remember I was talking about buying the drugs, having the person who orders them, the warehouses, the trucks. They've turned that all over to the government. It's not going that well. They also then have indigenous partners who are the NGOs, the non-governmental groups that they chose back in the day in 2004 when they had to choose between speed and public health systems, and they chose these other partners. Many of those partners were quote unquote indigenous. Uganda and all of these countries, let's remember, right, that all of these countries, it's not binary. It's not, do you have a health system? Do you not? Do you have researchers? Do you not? There is resilience, ingenuity, ambition, and infrastructure in every country, in every community. Nobody came into a blank slate. So in Uganda, there was a tremendous brain trust and infrastructure. That got funded. That's still there. There is a woman in Rakai, which is a southern district, who is not the pharmacist. I never remember her title, but she's basically like the head of their drug supply system. And she spends her entire day fixing the problems in the national medical store. So she knows where their drugs are, and she will sometimes drive from one district to another and move the drugs around, okay? So that's an example of basically, we didn't fix the problem. We didn't fix it. Uganda didn't fix it, okay? And there's culpability in the government there. And every country is different, right? But essentially, you have a country that has not increased its investment. Most countries that have received HIV dollars have not increased their healthcare investments. They actually haven't said, great, you've got that, let me build primary healthcare. They've said, great, let me do nothing, okay? So PEPFAR is now paying for both the government system and the local non-government group to fix the system. That is not sustainable, but that's also as far as we've gotten right now. And it is an interesting thing because when people say local ownership or country ownership, if you push hard on it, especially with PEPFAR folks, a lot of times they will sort of clarify they don't necessarily mean the government. So what does it mean? What does it mean for us in America? What does it mean for us as funders? What does it mean for people, for the woman in Uganda who's doing this workaround for the pharmacy? Like, that's her job. And I was like, is that messed up? She's like, yeah, it's kind of messed up, but that's what I do. Right. She's like, you know, how do we, the next, right? I mean, I don't know if this is the next frontier, if it's where we're at right now, is how do we take on the governments directly? How do we do that? I don't know. Someone said, I love that you transparent about what you do. I don't know anything anymore. I don't know anything, but I do know that these are workarounds to government inaction and neglect, murder. Okay, that's where we are right now.
I think like this conversation about funding like local NGOs versus governments or communities is like a really good segue into our Thursday conversation that we're going to have about decolonizing and disrupting global health funding and the way that it's currently happening. So please, if you are interested in talking more about that, definitely attend on Thursday. We have just a few minutes left, but we have Pedro say that culture can be a reason that there is a health gap. Yes, 100% agree. Someone asked about PrEP in Africa. Let's see. So I would, so since we only have 5 minutes left, like, Emily, if you want to talk about what you know about PrEP in Africa.
Oh my God, I love all these questions so much. Okay, so I mean, this is someone previous. So who's getting HIV? Well, there's a couple groups, but one of the groups, two of the groups that are disproportionately, meaning out of all scope and scale to their proportion of the population, disproportionately getting HIV. One group is adolescent girls and young women, and the other group is so-called key populations, which is sex workers, gay men, trans folks, people who inject drugs. Both important. I want to acknowledge both of them. I want to go back. I love this PrEP question because it takes me back to that little vignette about George H.W. Bush being called rubbers, and the devastating impact of having a U.S. global health foreign policy that divides a woman into the virus in her blood and her reproductive and sexual and reproductive health and rights. I don't think that we can successfully deliver PrEP in Africa as an American program. And we have driven, okay, we don't have all the power, but in some countries really have shaped the way that women's health and the way that health for young women is formed. Most young women are more worried, actively concerned about getting pregnant than they are about their HIV status, about acquiring HIV. Young people don't think of themselves as vulnerable, okay? So if you are given the choice between going to a clinic to get contraception and going to clinic at PrEP, you're probably going to go get contraception. This is what people have found when they've gone and talked to young women. If your PrEP isn't there and people aren't talking to you about it, you're probably not going to get it, and you're not going to be supported to stay on it. So that's not exactly what you asked. I think Richard, it's feasible. It needs to be there. But this, I would say, why is there a PrEP gap? One of the answers relates, for women and for young women in particular, one of the answers relates to this lethal white male segmentation of a woman's body. I'm borrowing from Lillian Moreko here, okay? She's the head of the International Committee of Women Living with HIV in Eastern Africa, dividing women between what's in their bloodstream and their reproductive organs. Oh my God, there's so many other good questions. There's a ton of stuff, Christian, on economic arguments and research and cost saving, and I think we can pull stuff. Someone just Googled me. The book's title changed. Guess why it changed? A novel coronavirus made that title seem unfun. I don't know why. I don't actually think COVID is funny. But I did have to change my title. Oh, that was private. So the book, forget that. I won't promo the book, but it is coming out in June 2021. Let's turn it back over to Health Gap before I read more private chats. Maybe my mom and dad will chat me. That'll be fun. They're both here.
Hi, mom and dad.
Why haven't they increased their investment in primary health care? I think because of donor. The number one reason is donor intervention, and the secondary reason is because the heads of state in countries that are taking loans are just like the heads of state that are in countries that are making loans, and they don't really care that much about poor people.
All right. I know that there are so many questions to be had, and if people want to ask me those questions in an email, if people are looking for resources about specific things, like maybe if you ask, we could share articles or books or podcasts or movies or however you like to consume your information. Definitely happy to help provide more information to people. Before we leave, I feel like we covered so much stuff in this call. That I would love for people to share like one word in the chat that they are leaving, like the way that you feel leaving today. Like I feel inspired. Okay. Energized, curious, motivated. Yes, these are all the things. This is good. These are all like, yeah. Sorry, go ahead.
No, I was just saying, I love the comments that are still coming. I love the use of the term gatekeepers from Derek. I mean, this is exactly who we need to keep on knocking down, and we're just not done. People are still telling us what's appropriate and inappropriate. I mean, we're so not done. I just want to shout out quickly. Someone asked about the Depivorine ring, which is a ring that can be worn in the vagina for up to 30 days that has a slow release of antiretrovirals that reduces women's risk of HIV infection. And the question is, what about Depivorine ring rollout? It's about $8. Is this going to be affordable? And I will say the history tells us we decide. We determine the answer to that question. And if we demand it, it will be affordable. And it will be there. We can do that.
Awesome.
Yeah. And another thing, on Fridays, I don't know if Emily, you mentioned this.
No, yes, thank you.
So for questions, we want to continue this conversation. So every week on Friday at noon Eastern Standard Time and at 3, we're going to do 2 sessions on Friday to have as many folks engaged as possible to continue this conversation so we could talk more in depth about these things and also kind of like talk about like how we could work together to address it, how we can cut the issue, how we can talk about these big systems and how we can like figure out who the person is that have power so we can create the reform and the changes that we want to see. Many of you all talked about some great things as far as kind of like bottom up systems, like how do we create like bottom up systems from community? We want to carry that conversation on forward. So we really hope that folks, this training series is a conversation, right? We're framing it as a conversation. So next Thursday, is going to be part 2 of the training series, which is decolonizing and disrupting and decolonizing global health. And then at Friday, we're going to continue the conversation. It's just going to be Emily, myself facilitating that with you all, so that we can begin the process of like actually building a movement for the changes that we're discussing here today.
Awesome. Thank you everyone so much for joining and making this such a fun and interesting conversation. I loved everyone's questions, everyone's energy. Thank you. And I look forward to seeing you on Thursday.
Yeah. Thanks everyone.
Cool.
Thank you guys so much.
Thanks, Bass. Appreciate you.
We're stronger together.
Yep.
Thank you.
All right. See everybody.
Thank you. Bye-bye. Bye.